the last speaker would be Dr. Saumya JAKATI.
So, good
Okay,
afternoon, everyone.
Yeah, with the topic of immunohistochemistry, when and how. Yes, please.
Thank you. I'm Saumya from LVPI. I'm a pathologist, so you need to see the view of tumors through my lens. So, this is what I'm going to speak on: the principle of IHC, the interpretation, pitfalls, and the troubleshooting, and how do you work up your case, and how do you choose a panel of IHC. So, I'll take this through a case-based presentation. So this is a 19-year-old female who came with complaints of protrusion of left eye for past 15 days. On examination, we see a palpable mass which is noted in the lacrimal gland fossa, and patient had inferior dystopia of the globe and lag ophthalmos of 2 mm and limitation of extraocular motility. CT scan showed an heterogeneous tumor involving the left lacrimal gland in the superior temporal orbit with multiple calcification and globe indentation. The superior rectus and the lateral rectus were not visualized. Margins were appearing fuzzy and the mass was pressing onto the optic nerve. There was no bone erosion noted. On MRI, it was noted to be a lacrimal gland lesion with a well-defined lesion at the skull base posterior to the right maxillary sinus and with a diffuse dural thickening, which was suggestive of an intracranial metastasis. Whole body PET CT showed soft tissue component intending the brain parenchyma, and other lesions were in the scapular ribs, right iliac fossa, and sacrum. So the provisional clinical diagnosis was left eye lacrimal gland adenoid cystic carcinoma with intracranial metastasis. So this was the HPE of the tumor, where we have a more or less monomorphous round cell population with traversing thick fibrovascular septae and necrosis. Now, the lesional cells, they were round with moderate cytoplasm, with a pale eosinophilic cytoplasm as well, and a round hyperchromatic nucleus. There were occasional mitosis seen. That's it. And the periosteum, the adjacent periosteum and the lacrimal gland were sent as well, and the periosteum showed involvement of the tumor, whereas the lacrimal gland was absolutely free of the tumor. So this was provisionally called as a malignant round cell tumor with periosteal invasion. Now what next? Is this diagnosis sufficient for us to move forward with the treatment? No. So we go ahead and do immunohistochemistry. Now, applications of the immunohistochemistry include the cancer diagnosis and classification, identifying the origin of the tumor for staging and predicting the prognosis, and in certain cases where immune-mediated diseases are there, we have to diagnose whether it is IgG4 related or not, and in certain cases of infectious diseases, and of course, for research purposes. So the basic principle of IHC is nothing but antigen is targeted with specific antibodies which are tagged with a detectable marker, which is either an enzyme or a fluorescent probe. So there are various detection methods, like the direct method, which just uses a primary antibody and an enzyme over it to detect the antigen. Then you have an indirect, where you add a secondary antibody and an enzyme to detect it. In the bridge method, you have a tertiary antibody, which is bound to the enzyme and that detects it. In biotin-avidin method or streptavidin method, you have a basic body of streptavidin, which increases the sensitivity of the detection. And you also have a sandwich method, where you have more of streptavidin added, which binds and creates a bridge kind of appearance, and that is used to detect the antibody. Now in tyramide, which is an aromatic based derivative of tyrosine, that is used for signal amplification in this particular technique, and that also is used to increase the sensitivity of the detection of the antibody. And in rolling circle amplification, this was primarily used as a PCR method, but later it was developed as a technique for antibody detection, where they use a DNA primer and they create a circular template which is bound to an enzyme labeled probe, and that detects the antigen. What we technically use in day-to-day practice is nothing but a polymer-based IHC technique, which uses the formalin-fixed paraffin-emitted tissues, We use heat retrieval, antigen retrieval system, and this is the section of the enucleation block where we have to see that. So we take sections of 5 micron thickness, put it in the microwave with 3 cycles, and then the antigens are retrieved. You have to break the formalin bonds to expose these antigens. Now these antigens are located at various places, which is nuclear, cytoplasm, or the cell membrane, to which you add a primary antibody and a secondary, and then you add a HRP polymerase, which actually enhances the sensitivity of the technique. And then to that you add a diaminobenzidine chromogen, which detects it. And this is how you see under the lens the positivity of the antibody. So when you are interpreting IHC, you use various terminologies to say how is the antibody expression. First, we determine by saying the intensity of the antibody. Strong if it is shows very high level of antigen present in the tissue. Moderate if it is patchy and it shows a little bit of lesser intensity than the control, and weak or no staining when there is no antigen seen on the slide. Pattern of staining, whether it is diffuse or focal, and staining location, whether it was cytoplasmic, nuclear, or it was membranous staining. Then how do you troubleshoot when you don't expect these results to come? So this was a case of schwannoma, and the antibody ordered here was a desmin. Desmin should not be showing up in a schwannoma. But what is that happening here? You can see that there was a control present in the tissue, which is brilliantly positive. But what happened here is that the tumor has already stained with desmin. Why did this happen? So there was an inadequate blocking technique where the endogenous peroxidase activity was more. The antibody dilution might have been wrong, or there have been a cross-reactivity with the endogenous antibodies, or the technician might have not washed it properly. And the second thing, this was a case of prostatic adenocarcinoma, metastatic to orbit, and this is a pancytokeratin. Usually you expect this to be very highly positive, but what you see here is just a minimal, a faint stain of cytokeratin. Why did this happen? Because of the antibody dilution, probably the issue with the protocol, or the blast storage was not well, and there was an inadequate antigen retrieval. Now, this is an androgen receptor antibody. What do you think this might have happened? You can see that the control picture is in the inset, while there is a scant or very faint staining. What could be the issue? This could be because of the insufficient antibody, because few of the cells have been labeled or is showing expression in there. So this is another case of a lymphoma. So here you see that there is inadequate application of the antibody. Here what you see is there is endogenous cross-reactivity with immunoglobulins. Now coming back to our case, the morphological DDs here was orbital lymphoma, granulocytic sarcoma, poly or undifferentiated carcinoma, and Ewing's Barbinet. So we went ahead and did IHC with CD45, which was negative, CD20 was negative, MPO was negative, PAN-CK was negative, CD99 showed membranous positivity, Ki67 were quite high, and NKX2.2, which is one of the transcription markers for PNET. This was a case of Ewing's bar PNET. So coming to case 2, this was a 65-year-old male who presented with diminution of vision in right eye and associated with redness and pain. He was diagnosed elsewhere as ocular tuberculosis, and he had no improvement in vision and was referred to the oncology clinic. His best corrected visual acuity was 2320, and this was the fundus photograph of the patient, where it showed inferior subretinal exudate, and there was a creamy white multilobulated lesion with overlying pigmented changes and a hyperemic disc. The B scan showed multiple lesions in the choroid with a hyperreflectivity in the retina. This is the OCT, which also showed lumpy bumpy deposits in the RP, and there was hyperreflectivity in the internal layer of the retina. So PET-CT also showed a focal subpleural metabolic activity mass which appeared like consolidation, and other than that they were mediastinal and hilar lymph nodes. Now this was the choroidal biopsy taken, which showed a faint acinar type of cells along with the retinal cells, and this was the morphology of the case, which also showed acinar pattern. Alcian blue was done, which showed intracytoplasmic mucin, and pancytokeratin was positive in this, and melan A was negative. We restricted to do more IHC markers because the patient needed the block for molecular analysis. So we have to be very careful when the patient wants to take for molecular analysis. The block you have to choose a very, very minimal panel based on the morphology you see. So how do you approach a case? You have to first look at the morphology, whether it's squamous or whether it's showing any acinar kind of morphology in adenocarcinoma, or a classic Indian file pattern like in lobular carcinoma. So you have to look at the morphology first and then decide what immunomarkers you're going to do. So next is whether you have to see whether it is of epithelial origin, and then you advise markers such as cytokeratin and EMA. Whether they are spindle, then you order Vimentin. If they are round cell, then do CD45 and other hematopoietic markers
So
first.
can you please
And
conclude?
then, yeah. And melanoma, if it is, then you do a melan A. So this is the basic panel. So you do it in panels based on the approach. And to conclude, IHC is a very powerful ancillary tool which provides important diagnostic and prognostic information, and histopathology of the tissues should be the basis of the choice of markers, and they have to run in panels, and every laboratory has to standardize their technique, and controls should be perfect before you do the test. Thank you. And this is our team at